And I would like to thank Bruce and the team at Sim1 for inviting me here today to present with you a little bit about the senior strategy and really talking about kind of how that really applies to a lot of the work that's actually going on in the room today. Because when you think about the work you're doing in terms of simulation, in terms of thinking about education and where it needs to go, it very much is in line with our thinking around the senior strategy and where that needs to move forward as well. So we're really going to focus on bringing everyone up to speed on what is the senior strategy, and then really start talking about what does simulation have to do with it as well. So in terms of our context, just to help set the stage, we know that Ontario is aging, and I was just actually at McGill yesterday with a bunch of medical students, and I said to them, what proportion of the population is actually 65 and older? And actually, they were saying about 50% of the population is 65 and older, right? And it was mainly because when you're working in a hospital, you're mostly seeing older adults. So it was kind of fascinating because only in a few years, their entire worldview had been skewed to thinking that, half of the population are older adults. And it's mainly because we know that 14.6% in Ontario of our population are 65 and older, yet they actually account for nearly half of our health and social care spending. And that's understandable because as we get older, that's when we're more likely to encounter health and social care issues. And actually, as we see it, this is why medical students in particular working in hospitals tend to be exposed to older Ontarians in particular. But we also know that Canada's that 93% of Canadians 65 and older actually live at home. They don't actually live in hospitals. And we also know that Canada's older population is set to double over the next 20 years, while its 85 and older population is set to quadruple. And this is what gets getting policy people very excited right now. And it's not that we didn't know this was coming, a long time ago. This is the result of the baby boom. So as of 2011, our baby boomers started turning 65 and better, and that population again is going to double, while that population 85 and older is going to quadruple. So there are those people who are subscribers to the concepts of apocalyptic demography. People like to say, sure, older people help build our country, but now they're not dying quickly enough. They're living longer, and therefore they're going to bankrupt our population. So, well, that's really not fair, and that's not really nice. But there's a group in the United States you may have heard of called the Grey Panthers, and they're actually a group of activist seniors. And one thing that they have a bookmark, and a friend sent me this bookmark recently with one of their popular slogans, and it just reminds us that aging is not a disease, it's actually a triumph. Right? And so when you think about that, our life expectancy in 1900 was 51 years of age. Okay, so just over 100 years ago, 51 years of age is how long you would live. So now you look around the room and you're like, maybe I wouldn't be around today, right? So now our life expectancy today is 81 years of age. But at the same time, when we actually built our modern healthcare system, when we founded Medicare in each of our provinces in the 1960s, our population at that time, the average age of a Canadian at that time was 27 years of age. And life expectancy wasn't beyond our 60s at that time. So you imagine, people are going like, wow, right? Because absolutely, when you think about if we're going to sit together today as people interested in simulation and health education, you're going to say, okay, well, we're just, when you were having this conference, theoretically, back in the late 1960s, you wouldn't be thinking about the care of older adults. You'd be simulating around what the average 27-year-old would need in a hospital, right? Or what sort of care they would need. So I always like to say the population has changed, but the system hasn't. And so the question is, how do we actually start thinking about our healthcare system, but also our educational systems related to the delivery of healthcare in relation to the reality of the population we're serving today? So again, this is why the students at McGill, and I think the students at University of Toronto and everywhere else, actually think that 50% of the population are actually 65 and older. Because when you look at the data from Ontario hospitalizations last year, 42% of our hospitalizations were accounted for by older adults, and actually 59% or 60% of our inpatient hospital days were accounted for by older adults. So you can imagine that I also thought by the time I finished my internship here in downtown Toronto that I was convinced that, growing up in Manitoba, I thought we do things differently, but in Ontario, you sell your house and you go live in a hospital when you turn 65, because we have 1.9 million Ontarians right now, accounting for 3.7 million hospital days. That's kind of 2 free nights accommodation for every older person, theoretically, right? So, and when you actually look on the right side there, you'll see that the average length of stay is longer the older that you get. And so, so it's something to consider when we think about aging and our hospital utilization patterns. So this was actually the piece of research that really made me really reflect on kind of what I was seeing as a medical student in a hospital, and many of our healthcare professionals, what we see in hospitals where many of us train versus what is actually the reality of aging in our society. So a researcher by the name of Walensky actually did a study where he looked at those individuals who were 70 and older. He looked at 7,500 older adults, and he actually followed them over a 7-year period. And he simply wanted to see how often they actually spent their time in a hospital, because I showed you a lot of data that would probably convince you that most people spend most of their old age in hospitals. And what he was able to determine was actually that the biggest chunk of the pie there, 42%, represented no visits to the hospital whatsoever over that 7-year period. It reminds us that if you're lucky enough now to make it to 65 in our society, you're actually going to have about 20 more years of life ahead of you, and 17 of those years are going to be in pretty good health. So that these individuals over that 7-year period, they might be staying in the workforce, they might be playing with their grandkids, they may be taking a cruise, doing something exciting, and spending no time anywhere near a hospital or many of our healthcare professionals. Another 24% were those individuals who are using the hospital once over that 7-year period. That might have been to get that elective knee replacement so that that individual could stay healthy and active and independent. And the rest of the pie that would add up to 100% were those individuals who used the hospital 2 or more times over that 7-year period. And in particular, Walensky focused on 2 slices of the pie, these 2 smaller slices being the inconsistently and the consistently high users. So what do we mean by that? Well, the consistently high users would be individuals who have diagnoses like congestive heart failure or chronic obstructive pulmonary disease, diseases that we know can regularly flare up on a regular basis and land you into hospital unless you have really good primary and community care as supports in particular. The inconsistently high users might also have those diagnoses, but they might also have a complicating factor, such as a mental health diagnosis or dementia, because we know just having a diagnosis of dementia increases your risk of hospitalization by 50%. But the basis of this work was that Walensky was able to help prove that actually only a small proportion of older adults are actually consistently extensive users of our hospital services. So only a small sliver, representing the majority of that utilization that we see as healthcare professionals in hospital settings, for example. So then Walensky said, okay, well, if it's actually only a small proportion of the overall population, the older population that are these major users of our healthcare system, is there anything other than those diagnoses that help to understand who these individuals are and what do we need to know about them? So in defining those highest users, Walensky discovered there were 3 basic factors, and he did this research back in 1995. And I like to show his work because it reminds us that there are a lot of bright people who knew about this stuff years ago, and we're still taking time to translate it now. So what he found were there were 3 factors in particular. One was the idea of polymorbidity. That means having multiple chronic health issues, at least in this case, 4 or more health conditions. So if you're that individual who has congestive heart failure, I bet you that person has underlying heart disease. I bet you they have high blood pressure, high cholesterol, and they may also have diabetes, et cetera, et cetera. You just need to have 4 issues, and that actually gets you into the category of a polymorbid patient. And if you look at all the spending on older people in the United States, 80% of the Medicare budget is spent on just those individuals with 4 or more chronic health conditions, okay? The next aspect is what we call functional impairments, meaning having 1 or more problems with one's ADLs or activities of daily living. And the easy way I remember my ADLs is the 5 or 6 things you do in this order every morning. You transfer from a lying to a standing position. You walk over to the bathroom. You toilet yourself, you bathe yourself, you dress yourself, and you eat something. Those are those basic fundamental tasks that we need to be able to do on a daily basis to stay independent on our own. And we know that these individuals struggle with one or more of those ADLs on a daily basis, right? They may need help through the CCACs to have a bath once or twice a week, for example. They may need help with a gait aid to help walk around the home, for example. And so that's something we have to consider. And then the third aspect is something called social frailty. Now, I think at this conference in particular, given there's such a heavy emphasis on technology, I'm sure people are saying, okay, now Dr. Sinha doesn't know what he's talking about because he's saying social frailty. We don't have social frailty anymore because we all have these, right? So how many are you Skyping with your mom and dad or your Twitter and Facebook? So yeah, we're communicating probably more with each other than ever before. But I'll tell you the story of my mom and dad. Mom and dad are aging in place in Winnipeg. They had 2 sons. First problem, they didn't have a daughter, okay? But they think they made up with it by actually having a geriatrician. But still, what good am I? Because they have 2 children, 2 sons. One's living in Baltimore, one's living in Toronto. So now I get worried because if something happens to mom and dad and they need help getting their groceries, unlike 50 years ago when we were more likely to be living in intergenerational communities or intergenerational households, or actually more likely to be belonging to social clubs, for example, or going to church or synagogue or mosque on a regular basis where you make friends now, I get concerned because, mom and dad, they just had another of their best friends die this week, for example. So now I start thinking, wow, if they need groceries, luckily now there's an app for that. But Winnipeg, snow shoveling. I get concerned every winter now because you know what? Me flying home every week to go shovel the driveway, not practical and a bit costly, right? So mom and dad told me the other day, there's some new neighbors who moved down the street. And what do you think I said? Go make friends. Go take them some curry. They'll love that, right? They'll shovel your driveway anytime you give them a call, right? So, and it's the concept that we're less likely to have those interpersonal connections, okay? And because we are less likely to have that, more and more people, in fact, 28% of Ontarians report that they are actually socially isolated, and 21% actually report, older Ontarians, this is our data, 21% say they have nobody else they can rely on to help them with their chores if they need help. Okay, so these are issues that are growing and we have to think about this. So you think about the individuals with those 3 conditions in particular, and then you just think what it's like to start integrating care within our system that we developed in the 1960s for older adults today. And then these are some of the challenges I observed. One is that we do very little to empower patients and caregivers with the information they need to navigate the system. We currently spend $49 billion, our dollars, to provide a variety of health and social care services. In downtown Toronto alone, there's 250 health service provider and community provider agencies. And I wonder if you knew that we actually had 250 provider agencies, and I wonder if you know how to contact any of them or who does what exactly, for example. When we interviewed 1,000 caregivers as part of the senior strategy last year, 50% of these Ontario caregivers said they didn't know what the CCACs were or what services they provide. At the same time, I got dozens of letters from people saying, Dr. Sinha, do you know that caregiving for me is a 24-hour, 7-day-a-week job? And it's stressful, and I don't have any help to do it. Again, a huge disconnect between what we provide and what people know about we actually provide. The other part, it's kind of our dirty little secret in Ontario, is that we don't actually require any of our health or social care professionals, doctors in training, nurses, social workers, therapists, etc., personal support workers, to learn actually about care of the elderly. It's actually fun. It's quite shocking. I've been working with personal support worker groups, and they said, yeah, our training doesn't really focus on care of the elderly. It focuses on those functional tasks, like how to bathe someone, but not how to actually interact with a person who you're bathing who has dementia or maybe what they're thinking about. And that's concerning because it doesn't create an ideal experience for the personal support worker who is a low-paid individual trying to do very, very intimate and important work. So we're not doing them a favor by not giving them the skills they need, or any of our health or social care professionals. And so we really need to start thinking about how do we make sure that we are empowering everyone to have that training. Because I thank all of you who subsidized my medical education at Western. I had a phenomenal grounding in pediatrics, thank you, right? But that's not really helpful when I've chosen a career in geriatrics, right? And then when we think about it, is that we actually tend to not talk to each other well within and between our sectors and professions. We really work as essentially as silos and not as a system. And then when you think about when we're planning our services, our healthcare services, we're often quite reactionary in the way we plan services, right? There's an article on the front page of the Toronto Star. We say, okay, put some more service there, as opposed to saying, wait a minute, if the number of older people in our society are going to double over the next 20 years, then what are the services that an older population will need? And are we actually making sure we're getting to that point where we have the right care in the right place at the right time? So when we also think about the care that we actually provide in our hospitals as well, you then have to think about with those issues of that older person who might actually have those high users that may have those issues of function, may have those issues of social frailty, may also have those issues of polymorbidity. I just wanted to give you a schematic of what it's like then for older people who are actually going through our hospital system today. So you take an old, because we're talking about simulation, so I'm going to tell you about my 100-year-old patient, Mr. W, or 103-year-old patient now, Mr. W. Mr. W basically lives on his own in a one-bedroom apartment just in downtown Toronto. He can wheel around with a walker. Cognitively, he's intact. But whenever he gets a pneumonia, and he had a pneumonia very recently, actually, but whenever he gets a pneumonia, he starts feeling tired. He feels weak. And because older adults are more likely to lose function very quickly because they have less bone and muscle mass on them, so they have less functional reserve, he starts having troubles doing his transfers, and that means that he's at higher risk of falling. So you take a functional older person, still like Mr. W, who can still wheel around and do his things with the support of a PSW as well. But whenever he gets an acute illness, he always has that functional decline. He has that proximal muscle weakness in his legs, and sometimes he starts to fall. And it was a fall that led him to come to Mount Sinai 3 years ago when I met him for the first time. You then take this, he was 100 years old at the time, so you then take Mr. W, who's had 100 years of routine, 100 years of history, and you stick him in an environment that's organized around the care professionals and not around the patients, right? So I don't know what time you eat your dinners and your lunches and breakfasts at, but we have very set times at the hospital. And so if you're a late night eater, too bad. Your dinner's cold by that time, right? We serve your dinner at 5 o'clock. I don't know about you. I've never had dinner at 5 o'clock, okay? Then the thing is, we strip you out of your clothes. I see nobody here is wearing the latest fashion at Mount Sinai Hospital, which is hospital gowns. Again, I don't know why they're not taking off. They're all the rage at the hospital, right? But clearly all of you want to wear clothes that distinguish you and share your personality and so on. But we not only strip people out of their clothes so that we don't even know who they are or what they like anymore, but then if your name's kind of hard to pronounce, we might call you dear or darling, whatever. Or Mr. W is a very long Polish last name, so we affectionately call him Mr. W. As well, and he actually enjoys that, but at least I asked them first, right? And then you actually have older people who are in bed because, again, whenever we get sick and we feel tired as younger people, we'll go to bed, we'll stay in bed, but we know that older people actually are going to be losing percentage points of their bone and muscle mass with every day they're just lying flat, meaning you use 5% of your function every single day. So for older people, bed rest can actually be deadly, and hence why you want to keep them mobilized and active as older people. And then there are issues of dehydration, malnutrition. There's an increased risk. We know lots of older people who go to hospital have a higher risk of having a dementia, which can then lead to a delirium. And then you think of having those multiple medications already because they have multiple health issues, and then you throw another medication in the mix at a higher risk of having a drug-drug interaction or an adverse reaction. So in total, our traditional healthcare system that wasn't designed for older people can be quite frightening because it can lead to physical impairment and deconditioning, decreased mood and negative expectations, and overall it can lead to the production of dysfunctional older people. In fact, we actually know that 1/3 of older people by the time they leave our hospitals have lost an additional ADL from the time they actually came into the hospital themselves. So you imagine now, you remember the people I told you are the high utilizers of our system? I already told you they're already missing one or more of their ADLs. So now if they have a 1 in 3 chance of losing another one of their ADLs, you only had 5 or 6 to begin with, that extra ADL you could have lost in the hospital could cause further problems, because that further loss can be associated with various things like prolonged lengths of stay, increased risk of bouncing back to hospital because we just send the person back home and we didn't realize they couldn't do X, Y, or Z now, so they come back to the hospital. This might actually mean they lose their independence and therefore they have to go into a long-term care home, and a loss of function is associated with a higher risk of dying as well. So why does this matter? And why is this important when we have this sort of knowledge? Because all of a sudden you can start thinking, I know for those of you who are simulation experts in the room, wow, if that's the experience we have here, what's the way that we can re-engineer that, and how can we teach around that a different process? And that's the work that I do. My day job that I have at the hospital is not only treating patients in all of these environments, but then also thinking about how do I re-engineer the system so we don't cause those problems in the first place. We don't actually follow that recipe for creating dysfunctional older people. Because frankly, I don't know about the rest of you, but when I go to hospital and when I'm in my 70s, I don't want that to be my story, right? I don't think any of us want it to. So when we look at ISIS actually helped us recreate that Wolinski study here. And what they were able to show us again was that amongst those who are 65 and older, and the $24 billion we spent last year just caring for our older population, we found that 10% of our older population, so 190,000 older Ontarians, accounted for $12 billion in healthcare spending. Okay? At the same time, we found the least complex older adults. So half of that 1.9 million population only accounted for 6% of the healthcare spending amongst older adults. So the opportunity here is, you remember that pie chart with the 42%? The opportunity there is, how can we make that piece of the pie much bigger? How can we support more older people to stay healthy and engaged and independent? And can we do a better job for that 10%? Those 10%, is $12 billion the needed cost for caring for them? Or when you just saw the story that I painted for you about how our system is not doing a good enough job integrating care, or what the consequences can be for older patients, maybe there's opportunities to do a lot better. And maybe by doing a lot better, by matching the system to the patients we have in front of it, we may actually be able to save a lot of dollars and do better care. And it's understanding that the reason why we need to do this is because we know how much it's costing us to care for our older population, and we know what it's going to cost in future. This is a slide showing how we spend our budget based on age in our province. And as you can see, as you go further to the right, as you get older and older, that's where more of our healthcare dollars are accommodated. That's understandable. But this, remember, we have a $11.7 billion deficit in Ontario this year. And we know that by 2030, this is actually what our healthcare spending is going to look like, largely accounted for by meeting the needs of an aging population. And that differential in spending between the $48 billion we spend today versus 20 years from now is $24 billion if we do nothing differently. If we keep running the mismatched healthcare system we have today, well into the future for every one of us who's going to age into that cohort as well. So when I see this, I see a huge amount of opportunity, one, to do things better for older people, and also to keep our healthcare system sustainable and publicly funded. Because our dilemma is this: the way in which our cities, our communities, so not just our healthcare system, but the way we fundamentally organize everything in our society is currently organized in a way that disadvantages older adults with chronic health issues. But at the same time, as Ontarians, our care needs, preferences, and values are evolving, with increasing numbers of us wanting to age in place. So that's Mr. W. That's a picture of him, as you can see. And you can see he looks much better than he did ever in a hospital gown. This is a picture taken when he was 100 years old. He still has Rubik's Cubes beside his windowsill there. And I always joke with him, the only way I can get them to look like that is if I don't touch them, or if I change all the stickers, right? But again, Mr. W's fiercely independent. He wants to stay at home. He wants to age in place. And so really he actually I asked him to be the poster elder for the senior strategy. And he told me the other day, I'm going to stay alive one more year just to see how this future political situation plays out. And he says, I want to see you get some more progress on the senior strategy done too. But he said, I think after 104 years, I'll be done, okay? So he has a very subversive sense of humor. So again, in 2011, the government of Ontario announced its new vision to make Ontario the best place to grow up and grow old in North America. And given our current and future challenges, the development of a senior strategy was established in 2012 as part of the new action plan for healthcare to help establish best practices and policies at a provincial level. When we started this process, when we started thinking about, well, how are we going to develop a senior strategy for the entire province, Ontarians right from the get-go were saying we want to make sure this is a process that we can be engaged in, but we also want to make sure there's some ground rules here and some principles here. We want to make sure that every principle or every recommendation that's going to come up here is really focused on how do we support older Ontarians to stay healthy and independent for as long as possible, but we want to make sure that it also adheres to some principles. So the principles that we chose really were equity, quality, access, value, and choice. Because people were saying that the real future for our healthcare system is if it really honors those 5 principles in particular. So it was a busy summer in 2012. I had 6 months from the start of the consultations to getting a report on the minister's desk. And really, we had over 5,000 older Ontarians and 2,500 health and social care providers, 1,000 caregivers. We had mayors, you name it, people participated in any way, shape, or form, which was amazing. And any group that had anything to do with aging, if they wanted a meeting, we met with them. So tons of submissions, tons of opportunities to dialogue with people, both provincial and nationally. And all of that came together as I started. Some of you who will have followed along on the path, you'll remember I was saying, I'm not writing this report on my own, we're writing this together. So people were submitting lots of things, cutting and pasting, putting it together, came into a 233-page report because there was a lot of stuff that needed to be said, and that report was called Living Longer, Living Well. This was handed to the Ministers of Health and Seniors and at the end of December, and I've actually been told the other week that the report has now been downloaded over 25,000 times from countries as far away as Bhutan, and actually I'm flying out on Saturday to Japan to present this to the World Health Organization because they said lots of countries are interested in what Ontario has actually put together. So for those of you who don't have a few days to read a 233-page report or the 166 recommendations, I'll give you the 1-minute summary here, okay? But it is good reading, okay? I assure you. So the key was we really focused on 12 themes, and these are really the chapters that evolved. And you'll see that the first chapter is really focusing on developing elder-friendly communities or age-friendly communities because people said our health and our well-being and our future as older Ontarians is about being a part and engaged in those communities. When we talked about social isolation and frailty, what are we doing to combat that? How are we making sure that there's affordable and accessible housing options for all people's various needs? How are we making sure that there's transportation services that will meet older people's needs, given that older adults are likely to outlive their decision to stop driving by 10 years? So what are we actually doing in that respect? How do we address poverty amongst older adults? Because aging in poverty, not fun. And then how do we also think about those other aspects, so those social determinants of health? How do we then think about, people were saying it's great that we're going to think about how do we repair our healthcare system to meet our needs when we get ill, but how do we actually stay well? What are the things we can do to stay healthy and active so that we actually don't need to be part of that 10%, but we can be part of that 50% who are healthy and well? And then what are the other things that we can do to improve the rest of our healthcare system, our primary care, our acute care, et cetera, et cetera? But also there were very specific things that we needed to focus on too. How do we better meet the needs of caregivers? How do we focus on those thorny issues of ageism and elder abuse? It's still too common and it's a problem. And how do we meet the needs of unique populations like our older Aboriginal peoples or our LGBTQ seniors? And then what are those enablers? What are those enablers that are going to enable a strategy for Ontario? And that's where a lot of what we're talking about today came in. It was really about thinking about the education that we provide, because if we arm all of our future and our current health and social care providers with adequate training and care of the elderly, then all of a sudden we're going to be a much better system overall in terms of the way we respond. But what are the things that we invest in? What are some of the things there? And I think Bruce has been sharing with you some of the investments that Sim1 has been leading around helping with training and support and education to really move this agenda forward as well. So in total, there were 166 recommendations. There were 33 broader recommendations that touched 7 different ministries, and one of the recommendations helped create the the new Ministry for Senior Affairs, and we now have our own Minister for Seniors in Ontario, who's working with 7 other ministries to implement the broader recommendations. And then we had 133 recommendations that specifically focused on health that were within the mandate of the Ministry of Health to lead the implementation of. And there's been a lot of good active work happening to get these recommendations implemented and moved forward as well. So overall, when we think about what are some of those opportunities to support aging in place, it's really focused on a few areas in particular. These are the things we've been working on actively across the province this year. So investing more in health promotion and prevention in older Ontarians. Some of you will be familiar with the physiotherapy reforms that have occurred over the past year. Soon, by the early of next year, we'll have 2,000 free exercise and falls prevention classes available across the province, for example, again, to help older people engage in things that will help prevent functional decline. Because last year there were 106,000 older Ontarians who went to our emergency departments as a result of a fall, and 26,000 admitted to our hospitals because of a hip fracture. We can do better. We also have some of the lowest vaccination rates amongst our older populations in the country. This is why pharmacists are now giving the flu shot, for example. This is why we're trying to really get more people informed about vaccinations that can really help them stay healthy and well. We're also trying to make sure that all older Ontarians who want to have a primary care provider can get one. And we've also made provisions in the last Ontario Medical Association agreement to encourage physicians to do more house calls. So we've actually already had 50% of our primary care docs doing house calls. And this year we've had a record number of house calls being performed by doctors for their patients. So some good news there as well. We're also strengthening and prioritizing current and future investments in home, community, and long-term care. Bruce has probably shared with you the investment that occurred around supporting PSW training. There went from 27% of PSWs, correct me if I'm wrong, to 95% of PSWs training programs now have access to simulation equipment and materials to actually help. I can't believe that only 27% had access to that equipment before. Like, that's crazy. But now 95% have access to equipment that actually can allow them to simulate the experiences of going into a person's home and actually do that sort of work. Also, other investments were like $10 million for our frontline long-term care home providers and directors. So 47,000 frontline care workers in long-term care homes got extra training in behavioral supports and other aspects to help them understand better how to care for older populations as well. We're also expanding traditional scopes of practice and practice settings, so looking at areas like community paramedicine, understanding supportive housing as well as an underutilized model of care to keep our system sustainable is another area that lots of investments have been occurring in as well. And then making sure that our future in health and social care workforce has the knowledge and skills needed to care for an aging population. So what I want to then finish off with was so how can simulation enable the senior strategy in particular? So as I mentioned to you earlier, when we looked at our 12 overall themes, the last theme in particular, last but not least, really looked at those enablers to support a senior strategy for Ontario. So again, for those of you who may have been taking a little bit of a snooze earlier in the presentation, here's your interactive component here. Who can tell me what unites these professionals, these professions? Our nurses, our physicians, our social workers, our pharmacists, our therapists, our physician assistants, as I learned with my folks at Michener, our chiropodists, and our personal support workers. What do all of these professional groups have in common? Wait, I can't hear people. You're quiet. The client, absolutely. But the other thing is that none of them are required to have training in the care of the elderly, right? And so, again, because none of them are required to have any formalized training, do you remember when Donald Rumsfeld a few years ago was going like the known knowns, the unknown knowns, you don't know what you don't know type thing? And so, again, when we actually worked with our nurses at Mount Sinai, when we developed our acute care for elders unit, these were all nurses who were taking care of older people for years and years and years. And then when we actually did a needs assessment, we actually determined that everyone on the unit needed 19 hours of extra training in in care of the elderly, just so that they could feel confident in just meeting the needs of frail older adults. We delivered that. Our commitment to them was we'll pay for that training. And now, oh my God, their scores and they're just doing phenomenally well. They feel much more confident and expert in that. But they told us, Samir, we didn't get that training in nursing school. We won't still get that in nursing school today. We need this sort of training so we can feel comfortable even working as a general medicine nurse. So again, we often don't know what we don't know, but we have an opportunity here in particular. So what have I learned? A lack of skills, knowledge, and training opportunities often affects one's confidence and comfort in working with certain populations. If you don't have those knowledge and skills, then how can you be confident in working with that population in particular? We also know that our educational training doesn't stop in school because professionals need to be involved in lifelong learning as well. We also know that the future of the care that we are going to be largely relying upon are really the care provided by unpaid caregivers. So those who are working at home as family caregivers, for example, our personal support workers and nurses, and our allied health professionals. And we need to do better for these groups in particular to make sure that they have the knowledge, skills, and confidence to care for an older population. And when we don't acknowledge or celebrate the achievements of a group often, it can be seen as devaluing the workforce as well. So I was really proud that this year the RPNAO, the Registered Practical Nurse Association Ontario, actually created their own award to recognize the top RPN in Ontario doing great work in care of the elderly. I mean, that was a huge thing that they did because they said, wow, it's a really nice award now because it recognizes to our members we value the work, considering that RPNs provide a huge amount of their work in working with older adults. So it's small things like that. It doesn't cost a lot of money, but my God, it really makes people feel valued in particular. So where do we need to go? So right now, in terms of, we need to think about establishing new interprofessional models of care because, as I always like to say, geriatrics is a team effort or a team sport. Encouraging evidence-based practices and guidelines will be important, and thinking about how do we enhance education and training opportunities by establishing those mandatory and relevant course content, making sure that we have more community and geriatric placements for all professionals, and then ensuring that simulation is a core aspect of the training we we give care providers, caregivers, and patients as well. So what does simulation to me mean in particular? So, how many of you heard of this phrase, see one, do one, teach one, right? How many of you have been trained doing see one, do one, teach one, right? So again, that's how I learned in medical school. I remember my training to do an IV was I remember sitting in a small seminar room with a nurse and 6 of my fellow medical student colleagues. We were given some equipment and said, okay, poke each other. Crazy, It wasn't a nice afternoon in our medical school, right? Literally we were slashing each other left, right, and center. But that's how I learned how to do an IV. The next time I actually did an IV, or actually to do a needle, was actually when I was doing a placement in a First Nations community up north, where I was learning how to stick a large bore needle into someone's arm. And it's crazy, when you think about how we do that. But hey, I saw one, I'll probably do one, and then God, you didn't want me to teach one after that. The nurses kept me away from everyone's arms after that one incident in particular. But we need to have a new method because when you think about it, practice makes perfect. When we think about role-playing with each other, role-playing with standardized patients, models, equipment, role-playing with above in a simulated environments, recreates real-life experiences in virtual reality. There's all these different ways in which you can envision simulation so that we get away from that old method and we really look at a new method in particular in terms of how do we actually support each other to really practice those skills, become confident in those skills, and manage the situation so that, especially when you're trying to work with older patients who are quite vulnerable and frail, you're not practicing your responses, you feel confident, and that way you can maintain the confidence of those people who we're actually caring for as well. So there's some innovative examples, and I apologize, I realized before this that the animation's a little bit off here. But, the Michener Group, for example, has been working on developing this really cool aging suit. I don't know if some of you have heard about it, but it's really cool. It's this suit that you can actually put yourself in like overalls, and then you can actually adjust, you can adjust various pressure points and straps so that all of a sudden you're forced to walk like this, for example, and in different ways. So you can actually start actually feeling what it's like. Because I just did a simulation exercise with our interprofessional group at the U of T Medical School and the nursing school, etc. And what we did was we said, put those goggles on, we'll tie your legs together, we'll do this, a real kind of a crude way of getting people to think about it. But it was really powerful for them to do something like that. But there are really cool techniques in which we can start looking at simulation and different ways of doing it that don't have to be terribly expensive. There's also simulation to teach how caregivers how to cope. So you may have heard that at Mount Sinai, we have a program called the Reitman Carers Program that really uses standardized patients to recreate challenging situations for caregivers to learn how to cope with and manage through situations. So, because I have patients all the time who are like, when my husband does this, I don't know what to do, and I just start yelling back at them, and it's terrible. So why don't we simulate that situation and get them to practice and feel confident? Because a more confident caregiver in that situation is one who's less likely to have problems coping and feel more confident and more likely to have their loved ones stay with them longer at home as well. And then simulation to teach patients how to regain their independence, for example. So, for example, recreating home and community care environments in rehabilitative settings ensures independence. So I remember when I was a medical student, when we'd say, what's the barrier for getting them home? We'd always say, well, how many steps to get into the home? And then what we would do is we'd actually have the person go into the stairwell and practice steps, because a hospital stairwell is exactly like your steps at home. Not really, for example, right? So now we have a staircase, a modeled staircase on our ACE unit, for example, not the hospital stairwell, but actually one where people can use it and where they're dedicated in that environment to using the staircase, as opposed to a busy stairwell where people are zooming by all the time to go on to their other things, for example. But also in rehab facilities at Hopkins, we had an entire kind of like Easy Street, for example, where we actually had a bus, for example. We had all these sorts of things where in our rehab setting, people could actually practice all those activities of daily living, so we could really see, can they go home? Can we see them in and out of a bathtub? And I do that with my patients when I do house calls. They always kind of giggle a bit, but I'm like, okay, here's the routine. You know the routine. Mr. W always laughs. But I'm like, we're going to the bathroom. I want to see you sit on the toilet. I want to see you get off the toilet. I want to see you go to your bedroom, sit on your bed, get off, because I can assess if they're going to fall in that. We can recreate those situations for them. And they laugh. But they know what we're doing here. And then we talked about simulation to teach aging sensitivity as well. So I just wanted to leave you with, because I think when we start taking these approaches, for example, and we start doing these things in better ways, we then start having opportunities when we can develop those elder-friendly approaches. So I want to give you this example of what we've done at our hospital, because what we've actually done at Mount Sinai is really try to really embrace this aspect of being an elder-friendly hospital. So in particular, in 2010, we really took the mantle of our board, our CEO, our leadership in nursing, interprofessional groupings in medicine, said, we're going to really make geriatrics a core strategic priority. And we started implementing our ACE strategy, which really thinks about a comprehensive and integrated delivery model that utilizes that interprofessional team-based approach to patient care. How do we all work together to better support patients? And really, it's relied on the strength of partnerships between all the different providers who are working with older patients in particular. One thing that we did was, in particular, when we were developing our ACE strategy, we really wanted to redesign or establish new approaches to enhance and improve upon current service delivery models. So, for example, we weren't going to change fundamentally where people worked in the hospital, but we want to make sure that everyone now had the training, the knowledge, and skills to work with older adults in particular. So every one of our frontline staff members now is given access to a training module called Aging 101. All of our nurses at the hospital have gone through it, which is it's a short course. It's an online module where they get to learn about aging sensitivity, where they actually get to see what it's like to have visual impairments. They get to understand what it's like to actually have hearing impairments as well. And the biggest fans of the group was our finance department, right? Our finance department loved it, because people were like, well, now I know when that person's calling me and they're hard of hearing, they're not asking me again because they're trying to annoy me. Maybe they can't hear well, and so maybe I have to speak a little bit louder. Like, it's that aging sensitivity that we talk about that's important. It requires, therefore, a shift in traditional thinking, because most hospitals, while 35% of Ontario's hospitals are now saying maybe we need to be focusing on the care of older adults, 65% of our acute care hospitals that serve older adults still don't think this is a priority. Boggles my mind, frankly. and then not being adverse to identifying risk factors and needs in intervening early to maintain independence. So really what we focused on is really thinking about our hospital not just as the emergency department, the inpatient and our outpatient settings, but also thinking about how we can start working with our patients in the community. So Mr. W, for example, is a member of our house calls program, right? So we deliver all of his primary care and his specialty care to him in the home. And we've actually just got a grant from the Toronto Central LHIN where we now have a telemedicine nurse, and we're actually getting all of our specialists linked in with telemedicine technology. So now he can speak to a dermatologist in the comfort of his own home, because getting Mr. W to the hospital, okay, not easy to do, right? So how do we actually start taking that care and that support in the home and doing that better? And then thinking about how do we deliver care that's geriatric focused and supported around the hospital community, and doing this really within existing resources, and a lot of it focusing on education. In fact, what we did with our MOVE program, which is our Maximizing Aging Using Volunteer Engagement, we actually select volunteers who really want to work with older patients and help frail older adults in the hospital. We run those volunteers through simulation training, where they actually work with standardized patients who are mimicking having behavioral issues or having various care issues, so that these volunteers feel comfortable. Because I don't know, but I've seen volunteers before, they go onto a ward for the first time, they said, go work with that person, they just don't know what to do. This way they felt much more comfortable in interacting. So again, a use of simulation in a population we wouldn't even traditionally think of using simulation that way. So is this effect actually having a good approach? Well, here's our data from the last 3 years in particular. We're now treating 31% more older adults today than we were 4 years ago on our medical units. So demand for this care continues to grow, but at the same time, we've dropped our lengths of stay overall, and they're now lower than the provincial average. Our patients are staying 72% of the time they're predicted to stay in hospital, because we're actually able to, by understanding their needs better, we're able to deliver care more efficiently, and we're more likely to actually get them home. In fact, if you came to Mount Sinai 4 years ago as an older adult, you'd had a 71% chance of returning home versus going to a long-term care home or rehab home. Our current regional average is 72%. Our record now is 79% chance of getting you back home where people want to be. And by being more efficient, we've actually been able to close beds. We've actually closed 8 of our beds because we can't keep them filled anymore, because we're running 31% even more patients through the hospital more efficiently. We've been able to reduce our readmission rates as well. We also did a lot of work with our frontline nurses. We did a whole campaign called Holy Moly, My Patient Has a Foley, and really saying, why does that patient have a catheter? Does it make sense? So we've actually seen our catheterization rates drop by 50% of the hospital. And this data, the catheter utilization ratio, says that for the remaining patients who are ever catheterized, well, before 56% of their time, they would have, their stay in the hospital, they would have had a catheter in place. Now it's only 14% of the time. So again, people really questioning and using prompting technology in our order sets to really promote that. And our patients are more satisfied with this care as well that they're receiving. So it's a real approach when you start thinking about how do we take education, because education is a fundamental pillar in terms of what we're doing. How do we use simulation in some various aspects there, and how do we actually start building that into the models of care we develop? Because if we didn't do that approach, we wouldn't have been as successful as we are. And we want to share this message with other people that you can do this within existing resources. And in fact, the reason why the hospital is really excited about our geriatric strategy is because our net savings last year alone, $6.26 million. So it pays, especially when the last 2 years in a row, our hospital, like all Ontario hospitals, have had a 0% increase in funding so that we could put more money towards home and community care. So when we think about what excellent care for all older Ontarians can look like under our strategy, we're really focusing on promoting wellness and access to elder-friendly, across our elder-friendly communities. We're thinking about supporting aging in place. How do we support Mr. W and his vision? How do we make sure that our hospitals in particular, where older adults, a few older adults spend a lot of their time, how do we make sure that they're more elder-friendly and providing that effective support across transitions? And how do we make sure for those people who will end up needing long-term care, that we have high-quality long-term care there for those who absolutely need it? So these are the opportunities that we have, and I will quickly lead you with one small story. Mr. W surfs the internet every single day. It's how he travels the world. And so he told me the day before I went to see him for this on this particular day that I said, "Where did you travel to yesterday?" And he said, "I went to Greece." He said, "I have fascinating things to tell you when I see you." I said, "Okay." So we confirmed the time that I was going to see him. And I said, "Look, I need to ask you a favor, okay? I'm going to be doing this thing called the senior strategy, doing this thing to support the government here. I want you to be the poster elder because we have some lovely pictures of us that I'd like to illustrate and tell your story because I think it'll resonate with others." He said, "I'll think about it and I'll get back to you when you can see me later." When he opened the door, when he opened the door, I was very proud of that because it meant he was mobilizing more. He had this really scowl. He had this scowl on his face, and I'm like, "What's going on? Where did you travel to today?" He said, "I didn't travel." I said, "Oh, is that why you're upset?" He's like, "No, sit down." And I said, "What's going on?" He said, "Look, I spent the last 2 hours Googling senior strategies for you because I thought my gift to you would be I'd find you one that you could copy and paste, and that way you'd have your entire summer off." And he's like, "I haven't found one that is really worthy of you copying and pasting." So he said, "You're basically on your own." He said, "Don't screw it up." And but he actually had this nice phrase, which I always like to end off with, was "This is Ontario's time to lead." So I want to thank you for your attention, and I think we have a few minutes for questions.
Do we happen to have a handheld mic? We do. Let's see if we can get a volunteer to grab that mic. And if you have questions, just wave down the mic holder. Well, I'll ask a question while we're waiting. I noticed all the examples you had for innovative simulation seem to be right here in Ontario. Would you say that we're also one of the leaders then in that as well, in terms of the simulation from the Reitman and the Michener and so on?
I think there's a lot. I mean, it's interesting. When I share people, I've been traveling around. I was just meeting with the Saskatchewan government yesterday and their leads because they're looking at how do they actually develop a senior strategy there as well. And as I've been traveling the country and looking around, there's lots of people who are thinking about how do we do innovative things in education. And you hear about virtual reality, hear bits and pieces, but I've never really seen a coordinated approach at a provincial level. And I think this is the exciting part. There's a lot of people thinking about this, but I think there's a real opportunity to say, how do we not duplicate things? How do we learn? Or the best thing that I was taught from my colleague at the Halton hospitals, she basically said, what we need to do, invest a lot more time people in is R&D. And people are like, "Oh yeah, research and development." And she's like, "No, you idiots. Rob and duplicate," right? So it's a matter of, saying if someone's created the idea, there's no benefit to say, "Well, I don't want to use your idea." It's, come on, we don't have time for this, right? We have an opportunity to say, when we create an open source format like this and share ideas through forums like this, it's an opportunity. How can I partner? How can we do this better? How can we spread? So if I encourage more investments in R&D, I hope you will take that further.
Is it ready? Go. Hello, thank you so much for a really incredible presentation on the work that you're doing. My name is Patricia Otaki. I'm from the University at Buffalo, and I'm really excited to hear about all the training that you're doing with all the professionals that you're in contact with. And I'm curious about two things. Mm-hmm. One is how you do your training. Is there any level of mastery, or is it more just time-based, like this many hours? And secondly, I've always loved the phrase that while practice makes perfect, perfect practice makes perfect. Mm-hmm. And I'm curious about the role of debriefing, and do you use any of that so that people are getting feedback on what they're learning through these simulations?
I think it's a great question. So believe me, I'm no expert at simulation training, but I'm an educator. It's part of what I do as an academic physician, and I help lead a lot of the work for our resident education and our medical student and our interprofessional education. I think for your latter question in terms about feedback, hugely important, right? We have a very, very robust structure at University of Toronto or anything where we are often debriefing and evaluating. In our general medicine clinic, for example, one thing that I also do, it's actually something I learned at Johns Hopkins, was in all of our clinics there, we have a policy that we don't review separate to the patient. They always have that phrase in Britain. They started, no decision about me without me, for example. And in this situation, what I do is, for example, in that example, in order to give the trainees feedback and to really see how they're interacting and dialoguing with patients, we say when they're ready, when they finished and they want to review that with the attending physician or whomever, we say, let's review with the patient. It scares the bejesus out of them the first time. They're like, what, we're going to talk in front of the patient? Absolutely. What are we hiding, for example? And by doing that, the patient and the caregiver become a part of the conversation. It forces us as care professionals to speak in a language that's accessible as well. And it's an opportunity for people to get direct feedback about what they're learning. Was I perfect in my understanding of the situation? And are we actually creating a care plan that works? So feedback, vastly important. When you talked about the other aspects of looking at about training and is it about quantity, is it about this, all I can speak to is I hear more and more people, and I think talking to the deans of many schools in Ontario now, I think the focus has gone around saying you need to have 12 hours in X, right? You need to do a course in X. So what I'm advocating is not that every school now has a specific course in geriatrics, but when people tell me that things are threaded through the curriculum, let's make sure that thread is bold and robust and not threadbare and about to snap in half. Let's make sure that that's a robust thread that gives people more of a competency-based approach, right? So what are the things that we think a graduating nurse or physician should have and be competent in, and where do we see them developing those competencies, and how are we giving them feedback and evaluation along the way as well?
Time for a couple of more questions.
I can repeat the question too. Mm-hmm.
Always refreshing to hear again. You said that 65% of acute care hospitals still don't think that this is a priority. So how do you see us addressing that? How do we support them recognizing the need beyond what we've done so far?
So again, people, you can tell that I'm, because I don't work for anybody but myself, I say whatever I want, right? So people always have the carrot approach and the stick approach, right? And so I think we've been trying to be very gentle with our organizations and say, hey guys, what do you think? And so we've gone from a few hospitals to 35% of hospitals saying they want to do this. I think really all hospitals in Ontario should be making this a core priority, other than pediatric hospitals in particular. So I think some of this is really about showing evidence. So I think what we've tried to do at our hospitals to say, hey, I know you're afraid of doing this because you think it's going to cost a lot of money or it's going to take a lot of new resources, but I just showed you, we actually have we can show we've actually saved dollars actually doing this care, and we've decreased our turnover and staffing. We've actually had a lot of different things that have actually been accrued benefits to doing this way as well. So I think sometimes I say, people say, is this time for carrots or sticks or shame? Shame is often an effective way of getting certain people to move forward. I don't think so. I think really the goal is going to be saying, how do we spread the message about this? How do we tell people that this is something important to do? And how do we show the business case that, frankly, this is good business, bottom line, so that even if it's your chief financial officer, our biggest fan at Mount Sinai Hospital, I have to say more than my CEO, is my CFO. Right? Joan loves this stuff because as you saw those numbers, that's music to Joan's ears when she's trying to balance a budget, basically. So she's always saying, what's next? What's next? What can we do? So I think, again, that's the approach that I would take in moving that forward. Please. Yeah, so that's great. So the question was, has Mount Sinai done any surveys or testing on kind of employee satisfaction or kind of or knowledge? So we actually have so that's a great question. There's an organization called Niche, Nurses for Improving the Care of Health System Elders. So we're one of the only niche hospitals in Ontario, but Niche has a wonderful programming. That's where we actually got our 19 hours of online modules from them. Again, rob and duplicate. They didn't have something on aging sensitivity that was Canadian appropriate, so we developed our own module, and we're giving that out to any hospital that wants it for free. So UHN is rolling that out now too. But if you want it, email us. We'll give it to you for free. The but for the 19 hours of extra training, we use that through the niche modules. They had all these care plans that are already created, and now we're actually going to be, the niche has asked Mount Sinai to partner with them to say, can we actually create Canadian versions of those niche modules, English and en français as well. So we're going to be working with them on that way. But niche also does something called the Geriatric Institutional Assessment Profile. So it means that on an annual basis, we're now moving into every other year, because we've done it 3 years in a row right now, we can actually survey all of our frontline health and social care providers, non-physician providers, and we basically ask them about, do they feel supported? Where are their areas of need, for example, and we actually test them on their knowledge and skills around certain areas of hospital level care. And in our first year, we're proud to say that we were well above the national average and the North American average. Now, if you look at our ACE unit in particular, they are like the highest ranking unit in North America. Their scores are through the roof, basically. And we have, and overall, the hospital has really lifted up in that piece. And so that's been really exciting. And we're using that as a way that we can monitor. And what we actually learned last year was where our nurses and our frontline workers were struggling the most was with behavioral management in our hospital environments. So what did we do with that? It's, again, knowledge and feedback, as our colleague was saying before. So we created now a program through a ministry grant called Safe Patients, Safe Staff. And that's a program where we're actually teaching frontline hospital providers how to better care for older adults with behavioral issues. And now we're working on disseminating that model to any hospital that's interested as well.
One last question from Dimitri.
Thank you very much, Dr. Sinha. My question to you is a shift away from the acute
Mm-hmm.
setting and to the community
Yep.
and to the home. What about the informal caregivers, children, friends, and family that look after the elderly, the demented, and the dying? What can we do to better equip them? Because they are probably our largest workforce in the healthcare sector to be prepared to deal with frail, elderly, and dying parents.
Exactly. So the question was really focusing on what are we doing to support unpaid caregivers who are providing the lion's share of care. I think the latest estimates are something between $25 and $35 billion of unpaid care being provided every single year by caregivers in particular. And how are we doing things? Are we doing anything to support them? So I guess my message here was it's not just about educating healthcare professionals, but it's also about educating our patients, empowering our patients, and also our caregivers as well. So I'm not sure about how many programs. There are some various programs. There are books people can read about how to be a caregiver, for example. But I mentioned to you our Reitman Center has been doing a lot of work, especially with caregivers of loved ones who have dementia, for example, in particular. And one is that simulation training you can do in a group setting. But recently, I can never get the names right, too many acronyms, but it's the Health Human Resources and it's HSRDC, that was the federal agency, partnered with Ceridian, one of the largest groups that does employee benefit programs, and some of their lead clients like Bank of Montreal, Royal Bank, and others. And they've actually created a working carers program so that for working carers now, you can actually do online training and modules and then group sessions where you can, again, get access to information on how do I be a caregiver? What are those things you need? And so those are just two examples of, I'm sure, many other things that are happening. But I think there's a huge amount of research out there that shows that if caregivers don't know how to access support and help, if they don't understand what they're actually caregiving around and how that illness, like dementia in particular, it's not straightforward. It's not like this is what they have and that's it, right? Dementia is one of those evolving things that if people don't understand the trajectory and what surprises may lay around the corner, it can catch people off guard and it can be very stressful. So I think it's opportunities to think about how do we think about caregivers and thinking about the simulation you're creating. Is there a way you can deliver that not just to healthcare professionals, but a patient-oriented messaging? And then how do you do that with caregivers as well? And I think we try and think about the caregiver in everything that we do at Mount Sinai, and I encourage you to do that as well.